and welcome to today's session. So today's session is a very, very special one, and it is of very good interest because we have a very famous endocrinologist who has a lot of experience in treating ophthalmology patients who will be talking to us. Ophthalmology is very, very interrelated to all specialties. Sometimes we may be the first person ever to see the patient and diagnose a condition which may even save a life. So as an ophthalmologist, we need to keep our eyes open so that we have an opportunity to actually see the stories that the patient's eyes have to say. Today, I mentioned that we are having a very, very eminent speaker, Dr. Anand Kumar Annamalai, who is a consultant endocrinologist at Ashwin Speciality Hospital, Nithila Hospital, and Vadamalayan Hospital in Madurai. He works also very closely with Aravind Eye Hospital. In fact, he sees all our patients who have eye problems along with endocrinological disorders. And that is why we have such a good working relationship with Anand. So Anand did his MD from Madurai Medical College. He was the API gold medalist, and then he completed his MRCP and FRCP in the UK. And he was almost settled in Cambridge. He spent close to 10 years as a consultant endocrinologist in Cambridge. And he was very, very academically innovative. He has written a lot of he has published a lot of papers, contributed to books, and also he has won the Best Poster Award in the British Endocrinological Society presentations. So today, I'll just share our plan. So after my introductory speech, Dr. Anand will talk to us, will share some of the patients with ophthalmological and endocrinological problems. He's going to present a series of cases. And after that, we will have a discussion. Dr. Mahesh Kumar, consultant ophthalmologist from Aravind Eye Hospital, will give us the perspective from the view of an ophthalmologist. And please feel free to post your questions in the chat box. And as and when the time comes, we will really put those questions to the endocrinology questions to Anand, the ophthalmology questions to Mahesh, and hopefully we will have a very, very stimulating academic session. So with these few words, I now request Dr. Anand to talk to us today. And over to you, Anand.
Good afternoon, sir. Thank you very much for having me on this platform. It is very exciting indeed to be actually doing a talk to eminent ophthalmologists and budding ophthalmologists across the country. So to kickstart, let me first. So before I kickstart, I hope you can see my screen and I hope you can hear me clearly.
Yes.
Thank you. So you all may be wondering why an endocrinologist in an ophthalmology chat show. So as mentioned by Dr. Prajna, it is very important that we look at the patient in totality. And as ophthalmologists, you actually reflect everything in terms of systemic manifestations. And this is why I've labeled this talk as Endocrine Reflections from the Eye. So my goal is to kind of learn and make you learn through a case-based discussion with integrating ophthalmology with endocrine conditions and actually weaving through the spectrum of systemic diseases and how closely it's knit with ophthalmology. With these cases, these are all real-life cases which have associated with Aravind, and I've learned from these cases, and I wish I'm able to portray whatever I've learned, and we could disseminate the knowledge in the right fashion. So we have to learn ocular examination, and we have to learn it in a way which would aid diagnosis of not just the eye, but the entire patient with several systemic conditions. And as I mentioned, it is very important that we actually look at the patient in totality. So in relevance to this, we'll kickstart with case number 1, which I've labeled as a red herring. So this is about a 34-year-old female who presented with a bulging eye, double vision, and weight gain for a few months. Now, the weight gain was significant of 5 kilograms within the past 12 weeks, and the diplopia also was present for the past 12 weeks. Along with this, in terms of her past medical history, for a young person, she had diabetes for the past 3 years, which was labeled as type 2 diabetes. She also had a high blood pressure for 2 years and was diagnosed with hypothyroidism for 2 years. Now, with all of these past medical histories, you can see a list of medications, which included a huge amount of insulin of 48 units per day. She was on metformin. She was on antihypertensives like telmisartan, amlodipine, and she was on Thyronorm 50 micrograms, which is levothyroxine 50 micrograms once daily. So the initial examination, so this was a patient who was actually referred to me from the Aravind eye care system. This lady had bilateral exophthalmos. She had restriction of ocular movements, and she also was found to be very labile in mood, and she was very anxious. With all these antihypertensives, she still had an elevated blood pressure with a blood pressure of 160/98. Now, the rest of the system examination was normal. Now, always in terms of any patient, whatever specialty you are, it is very important to look at the patient as a whole. And as we go through, you will understand what I mean in relation to this. So the initial diagnosis from the ophthalmological aspect was this was a thyroid-related orbitopathy. Now, initial evaluations from the ophthalmological aspects were done, and this is why this referral came through. So this is the lady. So I'll just pause here for you to have a look. Now, it is always important to understand when you're in the forest, you need to look at a tree, but you need to step back and look at the entire picture, the forest. And the same thing happens with medicine. In whatever specialty you are, you look at whatever specialty you are interested in, but look at the patient as a whole. So a little bit on thyroid-associated ophthalmopathy before we delve into what happened with this particular lady. Now, thyroid-related orbitopathy or thyroid-associated ophthalmopathy is in relation to antibodies formed against the TSH receptor. Now, the TSH receptor is present primarily in the thyroid gland. If you remember, the TSH comes from the pituitary. The TSH is thyroid-stimulating hormone, and that is under control by the hypothalamus, which actually stimulates the pituitary. The pituitary secretes the TSH acts on the thyroid, and the thyroid hormone comes out. So this is basic physiology. Now, the TSH receptor, although it says thyroid-stimulating hormone, may not be present only in the thyroid. Now, in relevance to someone with hyperthyroidism or with some form of thyroid disease, you could have thyroid antibodies. And with thyroid-associated ophthalmopathy, you have thyroid-stimulating antibodies or thyroid TSH receptor antibodies. Now, how does this occur? Now, this picture or cartoon tells you that the thyroid-stimulating antibody basically activates these receptors over here. Now, how do we get thyroid-stimulating antibodies? It is important to understand the primary stimuli is from the T cell. The T cell basically gets activated, and this basically, stimulates the B cell, and these B cells produce these thyroid-stimulating antibodies. And when these thyroid-stimulating antibodies act on the thyroid, the TSH stimulates the thyroid hormone, so you get hyperthyroidism. But this doesn't always happen. Sometimes the thyroid is quiet. It doesn't stimulate the thyroid. Now, instead, it stimulates in other areas. Now, the thyroid-stimulating antibody could act in the orbit. It could act also in the skin, because these are areas where you have this particular receptor. The thyrotropin receptor or the TSH receptor is present on the orbital fibroblasts within the orbit. Now, this is co-localized with an IGF-1 receptor. So they are like partners in crime. So these thyroid stimulating antibodies basically stimulate this thyrotropin receptor along with the IGF-1 receptor, causing a cascade of downstream events. Now, what happens with this? You have the orbital fibroblast, which is basically a mesenchymal stem cell origin cell. This basically gets differentiated. This differentiates into a myofibroblast, into muscle. This differentiates into a pre-adipocyte and an adipocyte. And all of these get stimulated with the orbital fibroblast through these receptors. Now, along with this downstream mechanism, you have an increased amount of glycosaminoglycans with increased hyaluronic acid. And all these are basically hydrotropic, meaning that they retain water. So what would happen in the poor orbit, which basically is a very small place? You would get enlargement of all these cells. The adipocytes, as I said, is derived from these orbital fibroblasts. They swell. The myofibroblasts in the muscle basically are derived from these cells. They swell. And you have the connective tissue with this hydrophilic molecule. So they swell. So you can understand in relation to all of this, there is a swelling, and this relates to basically a pushing of the eyeball outside, which results in proptosis. Along with this, there is a decreased blood circulation, which is literally like a constriction of the blood vessels going to that area. Now, the optic nerve obviously passes through that, so that could get basically constricted. So you can see how, this pathogenesis actually evolves. Now, if you look at these players here, the central player is the orbital fibroblast. But you have all these activated with the B cells and the T cells. Now, why is this very important? And why am I spending a lot of time in this particular cartoon? Because understanding of this, although we understand very little of this, is important to understand what therapies we can offer. So as I mentioned, the orbital fibroblast is important. The co-localization of the thyrotropin receptor, that is the TSH receptor, and the IGF-1 receptor acting together on the surface of this orbital fibroblast is important. Activation by the B cells in terms of the antibodies, the T cell with the cytokines is important. On the left-hand panel, you can see the various cytokines which are involved. You have the TNF-alpha, the interferon gamma, the IL-1 beta, the IL-6. All of these basically are joint culprits. So it is important, that these things are very important to control in terms of treatment. So pathogenesis of thyroid eye disease, to summarize, it is not always necessary that you would need to have an abnormal thyroid, because this TSH receptor may just be stimulated in the eye. So it is truly an autoimmune disease of the retroorbital tissues, and the thyroid eye disease may be a misnomer. And this is more common in women than in men. As I mentioned, the volume of the extraocular muscles, the retroorbital connective tissue, and also the adipose tissue is increased. And this is in relation to the cellular proliferation, the inflammation, and the accumulation of glycosaminoglycans with hyaluronic acid, as we mentioned. And this is the reason, whether it is a B scan, which you do from the ophthalmological aspect, or an MRI of the CT, you will find this kind of a predilection of an increased mass with basically cellular proliferation of the muscle, connective tissue, and the adipose tissue. The presence of TSH receptors on orbital fibroblasts, extraocular muscles, and adipocytes explains its role in the pathogenesis of thyroid eye disease. So, the T cell activation is initiated by the TSH receptor antigen. Now, what I mean by that is, now the TSH receptor is present, as I mentioned, on top of the thyroid gland. It's present also in the skin, and it's present also in the orbit. Now, we have certain ways when these antigens actually basically present themselves to our own immune system, and our immune system recognizes them as foreign. Now, how could this be? Now, this could be a spontaneous issue, this could be sometimes genetic, this could be environmental, and a host of other reasons why this could happen. Stress, smoking, etc. Now, this is a reason why, all these other factors, the controllable factors, are important, and we need to understand this in terms of management of this particular disease. Why do I say this is familiar? Now, if you look at twin studies, with monozygotic twins in comparison to dizygotic twins, the incidence was much higher. And if the next time you see someone with a Graves' ophthalmopathy, if you speak to the family members and you actually look at them, you will look at them in a different way. You would find that there is some amount of ophthalmopathy present in some of the individuals or the first degree relatives, which again tells us that there is an amount of genetic predilection towards this. Because as we know, not everyone with Graves' disease actually develops this particular problem. Now, TSH receptor antibodies, as I mentioned, activate the fibroblasts, and the adipocyte TSH receptors are also activated, and this results basically in all the issues with thyroid eye disease. Another important aspect is, does this always correlate with thyroid dysfunction? As I mentioned, thyroid eye disease is sometimes a misnomer. This is an autoimmune eye disease in relation to the thyroid stimulating TSH receptor antibodies, and it does not always need to correlate with thyroid functions. So ophthalmopathy appears in 40% concurrent hyperthyroid individuals. So at presentation, you may have up to around 40 to sometimes even 50% having some form of thyroid eye disease if you look at them from a clinical angle. Now, if you look at them after diagnosis, a further 20% may evolve into thyroid eye disease or evolve with problems with the thyroid hormone down the line after 6 months. Before the onset of hypothyroidism, again, there's 20%. So you get people who have a completely normal thyroid function and they actually have thyroid eye disease. And another number occur after what we do to them in terms of treatment. So that would mean whatever treatment we're giving them is not always perfect, and this can sometimes trigger it in some individuals. This particular interesting study was one of the largest in terms of people with hypothyroidism from a single center with Graves' orbitopathy. And why did I choose this particular study? This study was chosen because it's one of the largest, and this is just to make a very important point. Now, this was a study, an Italian study, and this particular center did not have a specialist unit with very severe thyroid-related orbitopathy. Now, when they looked at their patients, which included around 350 to 400 individuals over a period of 8 years, so it's a long time follow-up, there was no ocular involvement seen in most of the patients with newly diagnosed Graves' disease, which is very interesting. The moderate to severe and active Graves' orbitopathy or sight-threatening orbitopathy were rare at presentation and rarely developed during antithyroid treatment. Again, this is not something which we always see, and this may vary from place to place. Again, telling us that there may be some form of racial and genetic, predilections in relation to how people present. Greater than 80% of patients in this particular center with no orbitopathy at baseline did not develop orbitopathy after an 18-month follow-up, which again is interesting because, if you were to prognosticate people and if they had no presentation at baseline, the likelihood that they will not present it after a year or two is basically that it is going to remain, in a quiescent way. And remission of mild orbitopathy was seen in most of the cases. The other important aspects we're looking into the favorable outcomes. There was a stable, in terms of control of hypothyroidism, the thyroid eye disease was stable. They always noticed that, the outcome was favorable if there was an interaction between colleagues, especially endocrinologists and ophthalmologists. It's always a teamwork. And it was favorable if there was no smoking or the smoking basically was stopped. Medical management in moderate to severe cases, as always everywhere, was predominantly unsatisfactory. Now, as far as thyroid eye disease, 90% of people with thyroid eye disease have hyperthyroidism or overactive thyroid. Now, the remaining 10, 6 to 10 are actually euthyroid, meaning that they have a normal thyroid function, and the rest 3 to 4 or 3 to 5% have hypothyroidism. It is interesting to note that hyperthyroid or euthyroid patients with thyroid eye disease commonly eventually have Graves' disease or they evolve into Graves' disease. And as far as hypothyroidism, and this is an important aspect which we need to understand, now thyroid eye disease is not always about overactive thyroid. You could get people who are normal in terms of thyroid function tests, and you could also get people who have a low thyroid or hypothyroid function. And this could relate to people with thyroid antibodies, which basically block the thyroid hormone production. So it need not always stimulate the receptor we were talking about in the first cartoon. You wouldn't expect it to actually turn on the receptor and actually switch on the production. It could also block and actually switch off. A very important aspect also is in relation to the toxic nodular goiter and thyroid aplasia. Now, someone who has thyroid aplasia or no thyroid present, they do not develop thyroid eye disease. A very important and interesting observation, which would mean that if there's no antigen, then you're not going to get any antibody, and that means you're not going to get any thyroid eye disease, which is interesting. So how about the presentation? From an endocrine perspective, someone with hyperthyroidism, we would look at someone who has a severe bilateral and symmetrical involvement. With someone who has hypothyroidism, this is mild and it tends to be asymmetrical. Now, it is important to understand that it's just not the thyroid function test which need to be monitored or measured. It is important to understand that the thyroid receptor antibodies correlate very much well with the severity of thyroid eye disease. And the occurrence of thyroid eye disease also basically is an important diagnostic marker with thyroid receptor antibody. So it is important we consider measurement of thyroid receptor antibody in all cases with hyperthyroidism or thyroid eye disease. And we could consider thyroid peroxidase antibodies along with this. Stress and smoking play a vital role in the pathogenesis. What about technician uptake scan? Now, what does this mean? Now, this is basically, a scan where we actually use radioactive substances and we try to see whether the thyroid picks it up. Now, iodine basically concentrates in a very high manner in two tissues in the body. One is the salivary glands, and the other one is the thyroid. Now, the same transporter also transports technetium. Now, with this, we basically use this in terms of medical diagnostics, and we actually give technetium, and we basically measure the uptake of technetium in the thyroid. Now, if the uptake is significantly high, we know if it is diffuse and high, this is basically Graves' disease. And if it is patchy, then we know it's basically going to be multinodular or toxic nodule. And if there is a lack of it in uptake, then we know that this is just a form of thyroiditis. So this is the reason why we do this. But more importantly, the reason why I project this particular aspect in this forum is this is someone who basically had an uptake scan. As you can see here, there is a diffuse uptake entirely, but there is an area which is basically photopenic or cold area. So this is someone who actually had Graves' disease, who had a positive thyroid receptor antibody, who also had thyroid eye disease, but interestingly had a cold area. Now this cold area, with further follow-up, was found to actually have papillary thyroid cancer. Now this is pretty rare in someone who has Graves' disease, and in someone who's basically got a suppressed TSH, this doesn't occur. But it is important to keep our eyes wide open for these kind of issues. Now, obviously, you would have your friendly endocrinologist close to you who would actually be doing this, but it is important as an ophthalmologist to understand that these things can actually occur. So what about risk factors for thyroid eye disease? Now, age is an important factor. Now, older the age, the risk factor for thyroid eye disease is much higher. If you're a male, your risk is higher. Females have a more predilection towards thyroid eye disease, but the risk is much higher for males. And smoking is the biggest risk factor. It's also the kind of amount of thyrotoxicosis at presentation, which have been variably shown to actually also affect the risk in terms of thyroid eye disease, which can sometimes correlate with the level of thyroid receptor antibody. This again correlates with the volume of the goiter. Now, along with this, in terms of treatment, now why would treatment be important? Why would we need this partnership? Because if I don't do a good job, whatever you're going to do is not going to be good. So that would mean I would need to bring the thyroid under control quickly, but equally, I should not have TSH variability. If I have TSH variability, it will make the thyroid eye disease worse and will make your life worse. So the other important aspect is persistent elevation of thyroid receptor antibodies. And this could be because of lots of reasons. Why? One, primarily that, this particular individual may have had a very high thyroid receptor antibody at the onset. Number two, it's also what we do for it. If someone has had a radioactive iodine, that can actually result in the persistence of thyroid receptor antibody even after you've achieved a euthyroid state. So it's always important to understand what treatments these people have had. So as an ophthalmologist, when you get someone, it is important to ask them what they are taking or what they've had in the past. Now, if they have had radioiodine in the past, it is important to understand, even if it is 10 to 15 years down the line, you could still have a persistently elevated thyroid receptor antibody, meaning those antibodies could still attack your fibroblasts in your orbit, and you could still have thyroid eye disease, which may persist. What about thyroid eye disease and thyroid medications? A treatment with antithyroid drugs for 18 to 24 months has been shown to be effective in preventing relapse in most of the patients. And a duration of therapy beyond 2 years does not influence the outcome as far as thyroid eye disease, but it does influence the outcome of remission of the biochemical cure of thyroid. So the aim of therapy is to maintain thyroid hormone levels in mid-range, and that would mean it generally, we would want that the T3, T4, the free T3, free T4 needs to be within the mid-range. Don't always look at the TSH, because the TSH takes a long time to unsuppress. So it takes even up to sometimes 12 months to unsuppress. What about the role of antithyroid drugs and in terms of the inflammatory cytokines? Now, antithyroid drugs actually decrease the MHC class II antigen expression, which we spoke about in the first cartoon. And this reduces the intrathyroidal inflammatory cytokines, including the IL-1, IL-6, etc. And that means that they also have a role in terms of improvement of the eye disease. There are lots of regimes which could be used, but most important always is in terms of a titration regime with antithyroid drugs. In the place where I worked initially in Cambridge, we were used to a block and replace regime where we basically give a complete huge dose of antithyroid drugs and we replace with levothyroxine. And this is in relation to the high remission rate with the immunomodulatory property of antithyroid drugs at high doses. However, in the Indian setting, it is difficult because you would need these patients to actually come to you regularly. And if they don't, then they're going to land up in a problem. So you actually block them with an antithyroid and you actually simultaneously give them a levothyroxine, which basically would mean that you're taking control of the thyroid hormone altogether. And the levothyroxine given in this particular regime decreases the expression of thyroid antigens, and this also has immunomodulatory effects. What about indications for glucocorticoids? And this is something which all of you would have a question. Now, the first and most important thing, where do glucocorticoids have a major role? With dysthyroid optic neuropathy, this is number one because it could save vision. And this could save vision in 50 to 60% of individuals, and it could actually also avoid surgery. So remember, this is the most important thing. Another important thing to understand is although the clinically active TAO with the clinical activity score of greater than or equal to 3/7 was where you use glucocorticoids, this is not truly a disease-modifying agent. This basically helps in terms of the inflammatory response. It helps in terms of the reduction of the soft tissue, but basically it is not a disease-modifying agent. So how would you give it? This is in relevance to, what regime would you use? You would use a pulsed intravenous methylprednisolone administered over a period of 12 weeks, and the dose schedule is 500 milligram of weekly once methylprednisolone intravenously, followed by 250 milligrams over the next 6 weeks. So a cumulative dose of 4.5 grams. Failure of glucocorticoids, and this is something which we see a lot. Now, in specialist centers, because basically we get referred, most of these people will fail. In the other, particular trial, the study I showed you earlier, the Italian study, they said, they were practically didn't have, anyone with very severe eye disease. But, if you're in a specialist center, you would see a lot of these failure of glucocorticoids. And this is predominantly in people who smoke, in people who have persistent elevated thyroid receptor antibody, with a longer duration of thyroid eye disease and also thyroid, fluctuations, coexistent uncontrolled diabetes, coexistent uncontrolled autoimmune diseases like rheumatoid arthritis. The response rates generally are good, and that's thankfully we're happy that's there. So majority would mean greater than 60%. However, there's a failure of response in approximately 20%. And the relapse can occur in 10 to 20%, depending on whether the thyroid receptor antibody comes back again, or whether you have other factors also associated with this. The progression to dysthyroid optic neuropathy is less than 5%. So if there is no response to steroids after 3 months of therapy, now this is important, 3 months of therapy, because, it's not always that the first 6 weeks of therapy, it would result in actually a good response. It sometimes takes up to 12 weeks. And that's why we say no response to steroids after 3 months of therapy, then you go to your second line agents. You have a host of second line agents. I'm pretty sure we will talk about it with the discussion session. But basically, you could use rituximab, you could use tocilizumab, azathioprine, cyclosporin, immunoglobulins, and also monoclonal antibodies like teprotumumab, which are very promising. So radioactive iodine. Now, the indications, basically, we should not be using it in someone with clinically active orbitopathy. And equally, as I mentioned, if you have someone basically who's had radioactive iodine, it is important we keep our eyes open, because these are individuals who actually can have persistent thyroid receptor antibodies, and they can actually have thyroid eye disease, which actually persists. Now, in spite of this, some people may be offered iodine-131 radioablation. And this is why you need to know this. And why would you need to know this? So because some people are intolerant to antithyroid drugs. Some people have contraindications. Antithyroid drugs could cause actually immunosuppression by themselves. They could cause bone marrow suppression, and this could result in other forms of treatment. What about elderly and who have, people who have large goiters, cardiac failure? You would want, rapid correction, and that kind of a person, you would need to basically use this. And even individuals who actually persist and relapse in spite of optimal medical management. So these are people who actually would require this. So it's important to understand that these people may be coming through your doors. People with mild orbitopathy, the role of medical therapy. It's important to understand that there is a good thyroid hormone control, meaning that we have to avoid TSH fluctuations. We need to strongly ask people to stop smoking if they are smoking, and there's no indication for any immunosuppressive therapy in this kind of a person. There is a role of selenium. Selenium basically has an anti-inflammatory and antioxidant effect, and for a usage of 6-month therapy actually has a good evolved, a good prevention of progression in thyroid eye disease. So remember, thyroid eye disease is self-limiting, as evidenced by the fact that majority of the patients with active disease actually experience spontaneous remission. So although we're painting a bleak picture in the moderate to severe, it's important to understand that this generally is self-limiting. Coming back finally to our patient. So with that introductory note, so as I mentioned, for any patient, step back, look at the forest, not just the trees. So this person was sent for an endocrine opinion for a possibility of thyroid eye disease. And the clinical phenotype of this particular individual was suggestive of a particular condition. So if you look at her closely, so if you remember, I said that this person was mood labile, had diabetes with a lot of insulin on board, hypertension, and basically has, all these features which mimic a thyroid-related orbitopathy. This person had very high blood glucose levels, in spite of basically, having the insulin on board and all the other medications. So the clinical suspicion of this patient was Cushing's disease. So Cushing's is a condition where there is excess cortisol being secreted from the adrenal gland, which is under the influence of the pituitary. And when we say Cushing's disease, we mean that there is increased secretion of ACTH from the pituitary, which controls the adrenal in relation to the cortisol secretion. Cortisol generally has dynamics, meaning that it is very high in the morning, and as the day progresses, it basically, goes down to nil. And at midnight, it's practically absent. Now, if you have a very high cortisol at midnight, you're going to be awake all the time, and you're going to be crazy or cranky. So this particular individual had a cortisol in the morning, which was significantly high. For your benefit, I've placed all the abnormal results in red. So you would expect someone with a morning cortisol to be around 20 to 30. This is double. Now the midnight cortisol, again, is pretty high. So it's 46. You would expect it to be bang low at like 1. Now in endocrinology, if you have an excess hormone, we generally use a suppression test. So we suppress and we see whether it follows the physiology in terms of dynamics. So as I mentioned, cortisol from the adrenal is under control of ACTH from the pituitary. So if you give steroids from outside in the form of a tablet, you would expect that the ACTH from the pituitary shuts down, and it would shut down the adrenal production of cortisol. This would be the case in a normal individual. Now, this individual, after giving her 1 milligram of dexamethasone over here, you find that the cortisol is not suppressed and it is persistently elevated. Now, always in endocrinology, again, you have a negative feedback loop from the peripheral effective glands to the central control switches. So adrenal basically is controlled by ACTH. So if you generally have a high cortisol, you would expect that the ACTH to go low. Now here, you have a high cortisol, but you have an unsuppressed ACTH, which would mean you have an ACTH-dependent hypercortisolemia. which basically in simple words is basically, high cortisol coming from the pituitary. So this is Cushing's disease. So coming back to her. Now if you look at her, you can see that basically, she has a face which basically is mask-like. Someone who basically does not have, an elevated mood is more, looks depressive. And if you look at the skin, it's a little bit different. So you don't get the typical textbook descriptions of Cushing's, and that's what I'm trying to drive in here. You're not going to get your typical buffalo hump or the interscapular pad of fat. You're not going to get the moon facies. You're not going to get all those typical areas. It's going to be different. So this individual has high blood pressure, diabetes, it's got some skin issues, and also got ophthalmological issues. So we went ahead and did an MRI. The ACT was up, and what we found was a very small left-sided pituitary microadenoma. With this further treatment, we gave her medical therapy to control the cortisol output, and we gave her somatostatin analogs to control the Cushing's and orbital symptoms. And there were no steroids indicated for eye signs and symptoms, and that's what's important, because this is what I'm trying to kind of drive in over here. So we were talking about the indications of glucocorticoids in terms of thyroid eye disease. Now, if you see a thyroid eye disease, don't rush in and actually give steroids. Remember, this person's got steroids already floating around, like an ocean within her, and that's not controlling this particular eye disease. And this is not really truly thyroid eye disease. This is eye disease because of Cushing's. So we went ahead with biochemical control and did a transsphenoidal pituitary surgery. And post-pituitary surgery, there was a complete normalization of cortisol and a great clinical improvement. And from my aspect, it was excellent because she had a cure of diabetes and hypertension, and she was off all her medications. And from your aspect, there was a complete resolution of eye signs and symptoms. She was cheerful, and there was no mood or emotional lability which was actually present initially. So this was pre-treatment, and this was 3 months post-treatment. You can see the differences in terms of what this could do to an individual. Now, why am I presenting this particular case over here? Now, apart from, my initial kind of talk on thyroid-related orbitopathy and what we do with here, exophthalmos does not always equate to thyroid-related orbitopathy. There are other conditions to look at. That's why I said, just don't look at the tree, look at the forest, look around, look in totality. Why is it different? Now, 30 to 45% of Cushing's actually have exophthalmos, which diminishes with cortisol control. Now, I don't say this. This was said by Harvey Cushing's way back in 1932 from the Johns Hopkins Hospital records. Exophthalmos in Cushing's is different from TRO. This is in relation to fat redistribution and increased retroorbital fat. This could also be associated with thyroid eye disease, so it is important that you actually look into a coexistent thyroid eye disease. However, the importance here is the orbital muscles are spared. Remember, when we were talking about TRO, we spoke about the orbital muscles being infiltrated. And this is an important differentiating factor from TRO. Another important aspect is we were talking about the T cell, B cell, and also the cellular infiltrates, the glycosaminoglycans, the hydrophilic nature, all happening in the orbit. The retroorbital fat is supposed to swell because of all these cell infiltrations. But with Cushing's, the retroorbital fat is devoid of cell infiltration. Again, differentiating this from TRO. So there are only few reports of this, but as I mentioned, we started with the common things, but we also need to know about some uncommon presentations. There are only few previous reports with pituitary Cushing's with basically, a form of orbitopathy. Now, other cases have been reported with iatrogenic Cushing's, which is actually the most common Cushing's, and that's why I'm talking to you about this. So Cushing's is not always about pituitary and adrenal. They could be getting steroids from other reasons. That would also mean that if you give them too much steroids, you may also cause an exacerbation of your TRO. So our case is unique because of the complete resolution of the eye symptoms, the cure of Cushing's. You can see the difference in the eye with relevance to basically, the improvement with the treatment will be offered. So we were glad to actually have this abstract presented and, at the World Ophthalmology Congress. So to conclude from my end from case 1, the partnership between ophthalmologists and endocrinologists is vital. And this is important to improve outcomes in thyroid eye disease. It is important that we measure thyroid receptor antibodies. This is an important biomarker. If you could also measure thyroid peroxidase antibodies, but it is almost always important that the thyroid receptor antibody is measured. As far as Graves' disease or hyperthyroidism, antithyroid drugs for a period of 18 to 24 months is actually beneficial in relevance to thyroid-related orbitopathy. Cessation of smoking is very vital, and TSH variability must be prevented. If radioactive iodine has been offered as a therapy, beware, be watchful. Glucocorticoids with a clinical activity score of greater than 3/7. Immunomodulatory therapy in steroid unresponsive patients. And in mild cases of activity scores of less than 3/7, selenium can be considered. The second conclusions are the eye is an important clue towards unifying diagnosis. And as we started off, it basically is an important reflection of what's happening inside. Now, this truly was a reflection of what was happening with this lady, and we were able to kind of knit things together and get things better. Exophthalmos occurs in 35 to 40% of Cushing's patients. This is a forgotten clinical sign of Cushing syndrome. And as I mentioned, the fat redistribution, increased retroorbital fat, associated thyroid eye disease are pathogenic mechanisms, and a complete resolution of symptoms with cure. So with this, I will stop my case here.
Thank you, Anand, for a wonderful, wonderful case. I will now request Dr. Mahesh Kumar to let us know about, as an ophthalmologist, what did you learn, or what will be your advice to the young ophthalmologist? What are the top take-home messages from Anand's presentation? Mahesh.
Thank you, sir, and thank you, Dr. Anand, for that wonderful presentation. So as an ophthalmologist, what I have taken from this presentation is how do we differentiate a proptosis or a exophthalmos called the Cushing's disease versus a thyroid eye disease at a first sight. So grossly, when we look at a patient, an proptosis associated with other eyelid and soft tissue signs like an eyelid retraction or a lid lag, eyelid swellings, erythema, conjunctival chemosis or hyperemia, or some other currenticular congestion, gross congestions, we might think more in favor of a thyroid-related orbitopathy. And if these signs are grossly absent, if the eye is looking like in this case, the eye was looking relatively quiet, there are no congestion, but there was a proptosis. So if these signs are relatively absent, then we might think more in terms of a Cushing's disease. That will be my take home from this presentation.
Thank you, Mahesh. I invite the participants to put in their questions in the chat. In fact, we are able to see some questions already. The first question is to Anand. You can say, how to differentiate a proptosis caused by Cushing's disease and a thyroid disease?
That's a very good question, sir. So from an endocrine perspective, as I mentioned, I think, when we do scans, I'm not an ophthalmologist, but, when we look at scans, we look at the orbital fat. And the orbital fat is a very important differentiating factor from our side in terms of proptosis. So if we find a predilection towards, a fat volume expansion in comparison to basically the muscle and the general, connective tissue expansion, we actually think of other causes. So that's the way we would actually look into from an endocrine perspective.
Thank you, Anand. I think the take-home message for me as an ophthalmologist is be careful, be really careful, because we've been constantly taught in our ophthalmology practice that if the patient is having bilateral proptosis, it is more likely to be thyroid. And Anand very, very interestingly took this case explaining about a thyroid eye condition, and then coming with this diagnosis and explaining to us why this is not typical of a thyroid. And as Anand clearly mentioned, our traditional treatment for this would be, especially when there is a lot of inflammation, we would have put steroids, and in fact we would have killed her, right? Because as he says, she was swimming with steroids. And I think it was a very, very thoughtful gesture to correlate the lab results with the clinical findings and coming with a completely different diagnosis which mimicked the presentation of a thyroid-related orbitopathy. And because of the timely intervention, we could not only make her as a normal human being, otherwise you would have attributed her mood swings to just psychological disorders where there was, in the brain, there was something which was secreting and making her look like a psychiatric patient. And because of this timely intervention, we not only saved her life, but we also gave her a better quality of life. Again, I would request people to put in their questions in the chat box. I see a lot of questions coming up. Next question, is there any correlation between the severity of the eye disease and the TFT levels of the patient, sir? Do you really see the correlation in most of the time? I know that you made a mention that you don't see the correlation all the time, but do you really have a correlation between the severity of the eye disease and the TFT level of the patient?
That's a very good question, sir. So I think as we mentioned earlier, I think the thyroid function tests do not actually directly correlate with severity of the thyroid eye disease. But having said that, it is important to understand that, majority of people with thyroid eye disease would actually have an overactive thyroid, meaning that they would have hyperthyroidism. And, less than 10% and a kind of a split with people who basically have, a euthyroid picture, meaning that they have a normal thyroid function. So that would mean, obviously, it doesn't always actually correlate. But important to understand that these are people who eventually may actually evolve into some form of hyperthyroidism down the line. So it does not mean that if they are euthyroid at that point, they're going to remain euthyroid forever. So, that is an important aspect. And equally, as I mentioned, there are people with hypothyroidism with also, thyroid eye disease. In general, the ones with the hyperthyroidism basically have a more severe form of thyroid eye disease. And the better marker or biomarker which we have is in relation to the thyroid receptor antibody in terms of the number, in terms of that would actually correlate in a pretty good way. So the thyroid function test by itself is not exactly a great marker in terms of severity of thyroid eye disease. So you're muted, sir.
Sorry, Anand. We've got a lot of questions, but I'm just going to ask one final question. You mentioned a drug called teprotumumab, and you said it's promising. And the question is from one of the participants: can you tell us the use of the newer teprotumumab drug in thyroid eye disease?
Now, again, that's, we were talking about disease-modifying agents. So interestingly, although we've had thyroid-related orbitopathy for a, very long time, we actually don't have an approved, a modifying drug so far, up until a year or year and a half ago, when the FDA actually approved this particular drug called teprotumumab. So as it says, it's a MAB, which is a monoclonal antibody. And as we initially discussed, in terms of the pathogenesis, on the orbital fibroblast, you have this co-localization of basically the TSH receptor, and also we have the IGF-1. Now, as I mentioned, both are partners in crime, meaning if you basically get, the TSH basically acting on that receptor, you would need downstream mechanisms through both those receptors. So for it to actually cause all the havoc which it does. So now we have a drug which actually blocks the IGF-1 receptor component, and by doing so, it actually prevents the downstream mechanisms. And studies have shown that this is remarkable in terms of, improvement of basically the disease pathogenesis, because we have steroids, but it's not disease modifying. It's anti-inflammatory. It basically reduces the soft tissue signs, but it doesn't change pathogenesis. Whereas this basically is acting on the heart and the core of the pathogenesis. Now, unfortunately, it's not yet available in India. It is available in the West. It is available as an infusion. You normally give it once every 3 weeks for a total duration of, 24 weeks or 8 doses. So it's an infusion. So, we are very eagerly looking forward to this drug and approval of this. At the moment, it's pretty expensive, but this looks very promising and it looks very exciting indeed.